Acute kidney injury is a term that has now replaced the term acute renal failure, and it describes a sudden decrease in renal function occurring over a period of hours to days, resulting in accumulation of nitrogenous waste products and disruption of blood volume, electrolytes, and acid-base balance. The differential diagnosis of acute kidney injury includes pre-renal azotemia, renal, that's intrinsic, and post-renal as obstructive nephropathy forms of acute kidney injury. And the most important risk factor for the development of acute kidney injury is the presence of pre-existing chronic kidney disease rather than good medical care with avoidance of volume contraction, prevention of hypotension, and avoidance of nephrotoxic agents. No specific investigations have been reliably demonstrated to prevent the development of AKI as acute kidney injury. During management, a strict fluid input and output chart should be maintained. Acute kidney injury has been staged by the kidney disease as improving global outcomes working group for severity according to a criteria. That's the go AKI definition as an injury based on the Akin criteria. The stage 1 for serum creatinine criteria. Stage 1 is 1.5 to 1.9 times baseline or increase of more than 26.4 micromoles. Urine output criteria for stage 1 is less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. For stage 2, serum creatinine criteria is 2.0 to 2.9 times baseline. Urine output criteria for stage 2 is less than 0.5 milliliters per kilogram per hour for more than 12 hours. And for stage 3, serum creatinine criteria is 3 times baseline or increase in serum creatinine to more than 353.6 micromoles per liter or initiation of dialysis. For urine output criteria for stage 3 is less than 0.3 milliliters per kilogram per hour for more than 24 hours or anuria for more than 12 hours. Let's look at obstetric causes of acute kidney injury: septic abortion, post-cesarean section, severe preeclampsia or eclampsia, postpartum hemorrhage, and HELLP syndrome. That's hemolysis, elevated liver enzymes, and low platelets. Well, gynecological causes: bilateral ligation of ureters following abdominal hysterectomy. Medical causes include acute glomerulonephritis, hemolysis due to malaria infection, herbal medicines, typhoid fever, and GSPD deficiency, also diarrhea, vomiting, and dehydration. Surgical causes include hemorrhage, peritonitis, acute pancreatitis, obstructive uropathy, and burns. So the symptoms are nausea and vomiting, oliguria, anuria, edema, decreased appetite, metallic taste in mouth, hiccups, and change in mood, flank pain, fatigue, and diarrhea. Signs: usually no specific signs. Investigations: urinalysis, FBCB, creatinine, serum uric acid, blood culture, urine culture, abdominopelvic ultrasound scan, plain x-ray of abdomen. So the main treatment objectives are to recognize and correct reversible causes, to prevent further renal injury, to maintain a normal electrolyte and fluid volume, also to remove toxic waste from the body, that's dialysis. Non-pharmacological treatment For nutrition, you give protein of high biological value of 40 grams protein per day in adults, and in children 0.8 to 1 gram per kilogram of first class protein per day. Also, daily weighing, maintain fluid balance, beware of hyperkalemia, and avoid potassium containing foods, for example, bananas and coconuts. Pharmacological treatment, first line treatment. In the treatment of hypovolemia, you give sodium chloride 0.9% IV, or Ringer's lactates if there is no hyperkalemia in cases of diarrhea and vomiting, or blood transfusion in severe bleeding, or plasma replacement in cases of severe burns. In children, you give 10 to 20 milliliters per kilogram fluid bolus to re-establish diuresis after adequate fluid replacement. You give furosemide IV 40 to 80 milligrams stats in children, 2 to 4 milligrams per kilogram stats, and do not repeat. Control of hyperkalemia in adults, you give calcium gluconate 10% IV, 10 to 20 milliliters slow IV over 2 to 5 minutes, and soluble insulin IV 10 units in 50 to 100 milliliters dextrose 50%. And also you give sodium bicarbonate IV 8.4% as 50 MEQ in 50 milliliters, as 1 to 2 milliliters per kilogram over 5 minutes. I don't know what makes calcium gluconate and bicarbonate in the same delivery system. In children, salbutamol nebulized preferred. More than 25 kilograms, give 5 milligrams. Less than 25 kilograms, give 2.5 milligrams. Or calcium gluconate 10% IV 0.5 to 1 milliliters per kilogram, slow IV over 5 to 10 minutes. And then give soluble insulin IV 0.2 units in 5 milliliters dextrose 20%. And give 2.5 to 5 milliliters per kilogram per hour. And keep blood glucose at 10 to 15 millimoles per liter. And then use sodium bicarbonate IV 8.4% as 50 MEQ in 50 milliliters, 1 to 2 milliliters per kilogram over 5 minutes. Do not mix calcium gluconate and bicarbonate in the same delivery system. On treatment of hypertension, crisis, and encephalopathy, you address appropriately. Indications for dialysis are congestive heart failure, pulmonary edema, electrolyte abnormalities, especially hyperkalemia, not controlled by conservative means, so metabolic acidosis, uremic symptoms like seizures, pericarditis, hypertensive crisis, or encephalopathy. Referral criteria: you refer all patients with clinical indications for dialysis promptly to a center with facilities for dialysis.